Good morning, everyone, and thank you for joining us on this Saturday event. And as many of you know, I have firsthand experience with COVID, and obviously, as the years have gone on, the severity of COVID infections is diminishing, and we're only now starting to understand all the implications of COVID, its impact on not just the lungs, but all the body organs. And the heart, as being one of these organs, unfortunately, has become a target of this COVID infection. And so I just want to review what we've learned over the last few years. Most of this data has been observational. There's very little basic science research yet being published, and it's just coming out now as we learn what does COVID actually do to the heart. So why don't we get going? Next slide. Let's see. So I want to talk about the cardiac complications of COVID, a little bit about COVID and healthcare workers, and if we have time, sort of my experience as I survived that experience when COVID first was out in 2020. So what are the major complications? What do we see in the heart? So acutely, we see myocardial injury, heart failure, cardiogenic shock, and as well as arrhythmias, everything you would expect. The broad spectrum of influence of this virus on our cardiac system. Myocardial injury has been demonstrated, obviously, in the setting of COVID. There are many different mechanisms. Just the hypoxia itself has damaged myocardial cells. Takotsubo has been demonstrated. As you know, Takotsubo is a stress reaction driven by probably our CNS system. We have ischemic injury due to microvascular problems. Small vessel vasculitis, endotheliitis has been demonstrated with COVID. Obviously, we've seen complications of traditional coronary artery disease as well occurring in the setting of acute COVID infections. Right heart strain is a big problem, both related to acute respiratory failure, compromising our right ventricular function, as well as complications of embolic phenomena and pulmonary hypertension. And obviously ARDS, the pneumonia, having a direct impact on our heart as well. Myocarditis is a whole another subject, as this is probably the most commonly associated diagnosis that we see with COVID, yet the actual data behind myocarditis is quite lacking. And we have the systemic inflammatory response that obviously affects the heart as well as the rest of the body. So with regards to myocarditis, very common in patients with COVID that they have elevated troponin, and with that, they've been ascribed the diagnosis of myocarditis as we didn't know how else to explain the elevated findings. If you actually go into the literature and say, well, can we prove that COVID causes myocarditis? The answer is probably not. There's very few histologic studies published showing evidence of clear myocarditis related to COVID infection. And should have made these fonts a little bit bigger for me. Again, when you look at the COVID, they have never actually found direct genome inside myocardial cells. We have seen them in endothelial cells, lining cells, but not actually in cardiac myocytes. And obviously the other thought is this is an immune-mediated process from antibodies, and that is maybe more likely. If you actually go to autopsy studies, again, we cannot actually see the actual virions within the myocytes, so no proven direct infection of the heart. And if you look at MR studies in our recuperative convalescent patients, MR studies don't appear to show obvious myocarditis. Heart failure is obviously a big thing that we did see in COVID, both as a cause of heart failure and complications resulting from heart failure. So in a New York study of 6,300 patients, if you came in with heart failure as a diagnosis and you had COVID, you're more likely to stay longer, more likely to require a ventilator, and obviously your mortality was significantly higher. In Wuhan, among hospitalized patients, 49% of deaths had heart failure. And obviously almost all our COVID patients have high BNPs. So what does that actually mean? Not exactly clear. Right heart failure, very common, due to the strain of the right heart dealing with the lung issues, as well as pulmonary embolus and ARDS. Cardiogenic shock, majority were these were related to the hypoxia directly caused by the COVID virus. We saw the SIRS response, shock, and then obviously at the very bottom I mentioned that ECMO was obviously experimented with during our initial days of COVID and still used. So with COVID, we found that hypercoagulability was a big culprit in a lot of the complications. For those remember Virchow's triad, endothelial injury, stasis, hypercoagulable state, what lead to clotting, and all these are present. We have direct evidence of endothelial injury with COVID infections. Obviously our patients are immobilized, high risk of developing clots just in general, then stasis of blood flow. You see evidence of microvascular inflammation, all the things that you want to see that lead to clotting. The spike protein activates the alternative complement pathway within our clotting system. Lab tests, everything you'd want to see that makes you hypercoagulable has been demonstrated in studies. Elevated coagulation markers, lupus anticoagulant, antiphospholipid antibodies, D-dimer, all those are high in the setting of COVID infection. And obviously we can see ITP and DIC, which obviously complicates all our sick patients in the ICU. In terms of venous thromboembolic phenomena, very common early on in the setting of our hospitalized patients. In fact, almost a third of patients in different studies show that it was present in the hospitalized population, in the ICU, on the floors, and as we saw in post studies that almost all deaths were associated with some degree of pulmonary thrombosis, both on a microvascular and a large scale, more embolic type of situations. And very rare in outpatients with COVID. You got to be pretty sick to get these complications, and very rare after discharge from the hospital. Because of this, obviously they recommended anticoagulation for all COVID patients who were hospitalized. Myocardial infarction, and surprisingly, and I think we noted this at the heart hospital as well, during the first several months of the pandemic, there was a decrease of 40 to 50% in admission rates for acute MI, and that may have been a real finding, or it may have been that patients just did not want to come to the hospital, right? There were 3 studies here showing significant drops in those first 3 months of COVID where patients just did not show up with MIs in the hospital for whatever reason. If you look at the angioplasty rates performed during the first few months, those rates also declined significantly. And among patients hospitalized with COVID, there was obviously an increase in acute MI diagnoses. And odds ratio about 20% higher than other patients. And again, high number of COVID patients have elevated troponins during their hospital course. So pre-existing coronary artery disease was a very strong predictor of adverse outcomes with COVID. In a Chinese study of, again, this is just in the very early phase, so by February of 2020, where the rest of the world was just being introduced to COVID, there were 72,000 reports out of China, and if you had a history of CAD, they accounted for 23% of the deaths, which is obviously very high percentage, since they only were 4% of the admitted patients with COVID. So, and again, if you had pre-existing coronary disease and an elevated troponin, you did worse compared to elevated troponin, no disease, and no disease and elevated troponins, which is more intermediate. So, STEMIs, obviously if you had a STEMI with COVID, interestingly, you did worst. And if you look at the outpatient data, meaning you showed up de novo having your STEMI, your mortality was 15% for COVID, 11% without, not significantly different. But if you're in the hospital and then developed a STEMI, you were much more likely to die. And I suspect maybe because you were sicker with COVID, but what I read, there was also less patients who had COVID actually went to coronary angiography. Obviously, there was hesitancy on how to treat these STEMI patients in the hospital. There was delay in treatment, and the amount of angioplasties actually performed on COVID STEMI patients was much lower. Non-STEMI, again, I'm not sure what that means. Obviously, a lot of patients had high troponins, and whether this was a non-STEMI or myocarditis, pericarditis, that's the harder thing to sort out. Arrhythmias, not a big deal, honestly. Within the COVID, we did see it. One study mentioned that longer QTC was present in 6% of patients, and there were some implications of people using, obviously, chloroquine and hydroxychloroquine off-label, to treat their COVID. AFib was, 5% of AFib patients, of COVID patients hospitalized. Not surprising if your lungs aren't working well. Cardiac arrest, very high in the out-of-hospital setting. And in hospital, we did not see a lot of VT or VF. It was mostly, I think, end-of-life arrests that were not shockable. Let me go back one. So, is there actually a causal link between COVID-19 and coronary disease? And that is not yet known. They had one study out of the VA where they looked at the event rates of post-COVID patients, and it did seem to be a little higher. And whether that's more an observational thing or a causal thing is hard. As I mentioned, we don't have a lot of basic science yet. A couple studies that just did come out demonstrating perhaps some pathology as to why we're seeing heart complications with COVID. Here's two studies showing that in patients who had COVID infections, you could see that they actually had infected macrophages, the lipid-loaded cells that we see that are the causative agents in most plaque rupture. So they demonstrated that. Similarly, they can start to see markers of inflammation within the infected cells. So we're just getting to some basic information now as perhaps why we're seeing all these complications in the heart. So vaccines in the heart, obviously that's a huge concern for the population. It can cause myocarditis, pericarditis, usually in adolescent young adults, predominantly male. Much higher risk in the J&J vaccine, which I guess is no longer available in the US. So if you look at the VAERS data, our vaccine adverse event reporting system, in the first year and a half, 192 million patients received one of the mRNA vaccines, and 1,600 met the criteria for myocarditis, which you can see a very, very low percentage, 0.00085%. Okay. Most of these were occurred after the second dose. They were adolescents and male. So you look at the younger population, the 5 to 11 year age group, of 8.7 million doses of the Pfizer vaccine, there were 11 verified reports of myocarditis. And in the 1.5 million doses given to children between 6 months and 5 years, there were no reported cases of myocarditis. So very different what you read in the lay press. So what did we see as complications of the vaccines? Cardiovascular did appear to be the leading adverse problem. Within that segment, these were what were reported, led by atrial fibrillation. Myocarditis was actually third on that list. And within the clotting, thrombosis, CVA, pulmonary embolus, all those are present there. So getting on to healthcare worker. So here are the numbers for COVID. As of March 2022, over 79 million Americans had contracted COVID-19, and just short of 1 million people had died. In New Mexico, as of October 23, we had 673,000 reported cases. Obviously, a lot of cases were not reported, but the deaths are probably more accurate, and it came to about 9,000 as of October. So in healthcare workers, they said 3,600 U.S. healthcare workers died in that first year of our pandemic. Average age 59, 2/3 were minorities. And of the 6 million reported cases during that first year and a half, about 7% were in healthcare workers. So interestingly, if you look at the fatality among the healthcare workers, it was considerably lower than the general population. So 0.3% versus 24%. So within the hospitalized patients. So not exactly sure why. Maybe we cared for ourselves a little bit better than the lay person, I don't know. There were 3 surges in COVID infections, and surprisingly, the healthcare workers' surges only corresponded to that first surge and did not follow the other 2 surges. And not exactly sure why. Maybe we started to get more of the personal protective equipment at that point. And overall, yeah, there were very few N95 masks available. I don't think I ever had an N95 mask during that whole pandemic phase. Okay. Yeah, the people who died of COVID among the healthcare workers were generally older, male, Black, or Asian. And most of these deaths occurred around June of 2020, which I'm not exactly sure, but that was, 4 months into our pandemic. And they just thought it was because we were exposed, obviously, more, and underlying conditions, just like the general population, those really what correlated with your chance of survival or mortality. And this is a couple slides about masks. These are from the CDC. Cloth mask versus a surgical mask versus a respirator seem to have lower odds of catching infection. And however, I found this as a draft from the CDC, which I don't know if it's actually been published, but in this they had looked at all the studies out there with masks related to viral respiratory infections during the pandemics, and in multiple studies, I actually saw no difference in the type of masks that were employed. Okay, and obviously the N95 mask did some side effects. No, there's no difference in vital signs, but most patients complained of mild things such as headaches, difficulty breathing, nausea, skin problems, fatigue. And let's see. How much time do we have left? 1 minute. Okay, so as some of you know, I was one of the few survivors of the original bad COVID. And people always ask me, well, what happened? I think I have 48 seconds to let you know. So in the week prior to my catching COVID, obviously I was rounding in the Lovelace hospitals in the ICU, which was essentially a lockdown situation for COVID. So I was obviously exposed during that week. In that week prior to me being hospitalized, it turned out that my medical assistant was an asymptomatic carrier of COVID, which I discovered the morning that I got intubated. So I spent 3 months in the hospital with COVID, 1 month at Lovelace, 1 month at Kindred, and 1 month at Lovelace Rehab. That month at Lovelace, I don't remember any of it. I was admitted on July 4th, 2020, and I have a vague recollection on July 6th of going to the ICU and telling my colleague, Sophia Rogers, who was a nurse practitioner I had met in 1998 on the cardiac surgical service. I told her I could not breathe and that I had to be placed on a ventilator. When the COVID patients got put on ventilators, it was very different than your typical intubation. Most patients who are being intubated have no mental capacities. They're obviously critically ill, and their mentation is not normal. Surprisingly, most COVID patients were lucid at the time that they actually had to go on ventilators to support their respiratory status. It was a very awkward situation. I remember being in the ICU and calling my parents and my best friend and letting them know that I was going on the ventilator. The next thing I remember, it was a month later, waking up in the ICU. And from there, I learned that I had a brachial plexus injury, probably during the time I was prone for ventilation, and that led to weakness in my left arm. And to this day, that has kept me from returning to the cath lab. So I'm just in the office currently. I know my respiratory status will never be the same. Even though my pulmonary function testing has been all right, if I go up 2 flights of stairs, my SAT falls to 85%. So I know my lungs will never be the same. I have to thank all those providers at Lovelace ICU, at Kindred, and Lovelace Rehab. Having been in the hospital for 3 months, I had to learn to eat, I had to learn to walk, and a very trying experience. But having never been in the hospital is a very different experience to be the patient rather than the provider. But I have to thank all my colleagues who took enormous and wonderful care of me. Dr. Yao, one of my colleagues, came and saw me every day in the ICU while I was there, exposing himself obviously to the virus, and all the nurses and the physical therapists and occupational therapists. I have a newfound respect for them, as I really never knew how they took care of people. We would write for physical therapy and occupational therapy consults in all our ICU patients, and now I understood exactly what role they played in helping patients recover, from their critical illnesses. And let's see, there's one thing here. We're going to finish right there. I think I need help from the technicians to hit that button down the play. There should be a play button. So this was 3 months and 1 day after being hospitalized of, me walking out of Lovelace Rehab. So these were all the colleagues that I had from across the street at the Heart Hospital and the Heart Institute who met me as I left the hospital. Are there any questions I can answer for you guys?
Hi, Dr. Kim. Thank you for the wonderful presentation. I see I know in the acute phase it's not a problem, but in the outpatient setting, I've seen multiple people that have had COVID who have end up with severe dysautonomia and POTS, and I wondered if you could comment on that.
I mean, obviously, we know that COVID affects every system of the body, including the autonomic system. After my discharge, I had some nerve conduction studies due to my brachial plexus injury, and the neurologist told me that nerve conduction in my entire body had been disrupted when they, did not just my arm, that everything had been slowed down. We do see POTS in the post-COVID population. I haven't seen any clear literature as to why. Obviously, again, as we're learning the physiology of the COVID virus, maybe we'll know the answer to that. But we know that COVID infects the brain, causes significant inflammation in both the gray and white matter areas. So obviously could have a direct impact on the sort of, neurocardiac axis, that manages blood pressure, heart rate, and all those things. I have not seen anything specific for POTS and COVID, however, as a explanation. But I think all of us in the cardiology clinic probably have one or two post-COVID POTS type patients.